So I'm Krina Patel. I'm an MD. I'm the section chief and research lead for multiple myeloma at MD Anderson Cancer Center here in Houston, Texas. So this study, I think what's really important, KarMMa-3 was our first phase 3 randomized study for CAR T in multiple myeloma, patients who are relapsed refractory. And we know the PFS was much better. So CAR T PFS was about 13.3, 13.4 months versus standard of care was 4.4 months. And of course, that was the, primary endpoint, et cetera. But this study that we did for IMS actually was a little bit more creative in looking at quality of life. We've had other studies with KarMMa-3 that we looked at quality of life, and in general, per our surveys and screenings that we do, it looks that patients, when they're not on treatment, have better quality of life than when they are on treatment. But our team actually, looked at this a little bit differently. So what they did, we have patients in Arm A. There are about 254 patients who got CAR T. So, they got leukapheresis. They got possible bridging therapy. It wasn't required, but possibly got bridging therapy. Then they got their lymphodepletion, and then they got their infusion of their cells, ide-cel, just a one and done. And then there was follow-up. And then in treatment Arm B, those are the patients that got standard of care. So DPD, DVD, IRD, KD, or EPD. And the PIs got to pick based on what the patients had previously. And those patients, once they started treatment, they were kind of continuously on it until they decided that if there's toxicity or if they were relapsing. And again, these are patients that had 2 to 4 prior lines of therapy, and 95% of these patients were refractory to anti-CD38 and had had an IMiD or a PI. So, it was a requirement that they were triple class exposed at least. And then they had to have disease progression on or within 60 days of their last myeloma therapy. And so what we were able to do is section off into 4 different groups, different time points for both Arm A with ide-cel or Arm B with standard regimens. And basically, we were able to show patients who were on study treatment and hospitalized, patients who were on study treatment but not hospitalized, patients when they were not on study treatment but they were hospitalized. And then the biggest group for the CAR T was study treatment, that they were not on study treatment and they weren't hospitalized. And in the end, I'll talk a little bit about how we correlated this with quality of life as well. And so with the ide-cel arm, most of those patients, the majority of the time, was spent in no study treatment because it was a one and done, and then they're off all treatment and they weren't hospitalized. When they got their study treatment, a lot of those patients were in the hospital from the time that they got their cells until they got out of the hospital, which on average was a couple of weeks. And then we also called the time that they were on study treatment and not hospitalized, basically the time from when they got leukapheresis through bridging until they actually got to their LDC chemo. So again, for the ide-cel arm, most patients were in that study. They weren't on study treatment. They weren't hospitalized. Versus in the standard regimens arm, most of these patients were on study treatment, but not hospitalized. So again, there's a few patients that got admitted because of infections or something else, and they had to be in the hospital for that reason. But again, for the most part, these patients weren't, they weren't getting their treatment in the hospital. And then when they were outpatient, they're getting treatment the entire time. So then what the team did was looking at that quality of life. And so we looked at those patients who were getting ide-cel versus, the standard regimens. And again, one-time infusion with ide-cel was associated with better quality of life for patients relative to standard treatment regimens. And so at each time point, so for patients when they were on the study treatment and they were in the hospital, the quality of life measures for patients who actually submitted them was 0.6 for those who were on the ide-cel arm versus 0.44 for those who are on the standard of care arm. And relatively, full health is 1 and no better than death is 0. So again, that's the scale. So the best one was the study treatment. Patients were not on study treatment and they weren't in the hospital. That was 193 patients in the ide-cel arm. And again, theirs was 0.8, which actually compares to a survey they did in the UK for 8 patients of the same age that don't have any medical problems. So they were actually back to what we would say normal if we compared those. And then for the patients who were on on the standard of care, there's only 2 patients that were in this group where they were not on study treatment and not hospitalized, because again, then usually that meant they were relapsed. But there are 2 time points when this happened, and it was 0.66 for those patients. So even then, a little bit lower score than what it was for those on the CAR T arm. So just a different way of really looking at quality of life. And so the other piece we did was looking at putting this together. And so patients that received ide-cel experienced significantly longer quality of life, adjusted event-free survival than patients that received standard regimens. So again, the 225 patients that received ide-cel, they had about 14.48 months where they were, again, not on study treatment, not hospitalized, with, the event-free survival, versus with the standard regimens, it was about 6.64 months, where again, when patients were not hospitalized, they had better quality of life. But most of those patients were on study treatment while they're also not hospitalized. And so again, there's a difference about 7.84 months in that quality of life adjusted EFS. And again, this really just kind of tells us that this is similar to patients who are in the general population. So as much as it's really important that we look at efficacy in terms of, overall response rates and EFS, that quality of life piece is really important, especially for our myeloma patients, when they're on constantly multiple therapies for decades now. And so it was a really fun study that we were a part of, and hopefully we'll have a paper soon with all these really cool graphs that show the differences in how we define quality of life at different time points for patients getting CAR T versus those getting standard of care regimens. I think that's the biggest question for my patients, right? So every patient, I just saw somebody maybe a couple hours ago that I talked about this is, when you have a chronic disease, and I don't like it when people say myeloma is like diabetes or hypertension, because it's not, it's different. But it is a chronic disease in that patients have to take therapy forever and ever. And that's been the paradigm up until now. And so to have something where patients come back to me at day 30 from their CAR T and they tell me, Dr. Patel, I feel normal. I feel back to where I did before I was diagnosed with myeloma. And I can't tell you how many patients have said that to me. And then that continues over years, potentially. That is huge, and again, this study, I think, really shows us that when people are off treatment, they're not getting side effects. Most of us think about toxicity being bad at grade 3, 4, which, yes, that is bad when patients are hospitalized for toxicities or, it's life-threatening. That's not good. But even the grade 1, 2 side effects sometimes can really, cause issues for patients, especially when you're on these treatments long-term. And again, once you're on a standard of care option that's, continuous therapy, when you relapse, your body is in a different position and you've relapsed, and now you have to go on to the next therapy, versus when you get CAR T and eventually if you relapse, which, most people do, it's not curative for most of our patients as of right now, but when they relapse, they're feeling really good and they haven't had treatments and their counts usually are better and they're doing better, so that the next treatment that they get, they actually go in, with a better milieu of their, basically, their other organs and just in terms of how they were doing. That usually their functional status is better because of that. And so again, I think this study just kind of shows that with different numbers, but really something that I think is important when we think about, efficacy for our patients, which is really important. Survival is important, but how can we do it in a way that actually makes it less, patients don't have to pay for it with more burden of symptoms over time. I think that's really important. I think in the end, that is going to allow more patients to survive longer because they'll actually be able to undergo more treatments down the road if we give them more treatment-free periods.